Thank you for taking part in this workshop for the RADOSS project. My name is Adam Noble and I'm one of the investigators for the project. I'm going to briefly give an overview of the RADOSS project and of today's goals. As we know, a key ambition of the NHS long-term plan is to ensure people get the right care at the right time in the optimal care setting. To help achieve this, ambulance services should only be conveying people to hospital emergency departments if it's clinically appropriate or there is no alternative to provide safe and ongoing care for that patient. Our project seeks to figure out a way to support the ambulance service to do this. In this project, we are focusing on just one particular presentation, namely suspected seizures. That's why our project is called RADOSS, which stands for Risk of Adverse Outcomes After a Suspected Seizure. Seizures are a topic of interest in their own right, but they're also acting here as an exemplar for other conditions where opportunities for more non-conveyance exist. Before I continue, first a bit about us. On the slide you can see the members of the team that's leading RADOSS. We come from the Universities of Sheffield, Liverpool, the Yorkshire Ambulance Service and Epilepsy Action. The team includes expertise in neurology, emergency medicine, general practice, urgent and emergency care and its data sets, and importantly also includes those who themselves live with seizures. RADOSS is being funded by the National Institute for Health Research. So, back to why we are doing the project. As you all know, ambulances are often called to see people who've had a possible seizure. They are responsible for over 210,000 999 calls each year in England alone, making them the 7th most common presentation seen by crews. Nearly all of these get a face-to-face response. Once the paramedic has assessed the patient and ensured they're not in immediate danger, there's an important decision that needs to be made. In short, should the patient be taken to a hospital emergency department or not? Might it, for instance, be more appropriate for the person to stay where they are, say at their home, or perhaps be taken to one of the NHS's urgent treatment centres? We know answering such a question is crucial for the patient, the paramedic, and the wider urgent and emergency care system. Leaving the wrong patient at scene could expose them to unnecessary risks. For instance, they might experience a complicated seizure and no longer be in close proximity to the help they need. On the flip side, taking a person to a type 1 ED who does not require its facilities results in a so-called avoidable attendance, and we know these are not without harm. As well as being potentially inconvenient for the patient, they can expose them to unnecessary tests and investigations. There are also implications for other patients since avoidable attendances restrict ED capacity. Over the years, we have completed a number of interview studies of paramedics on the topic. This research consistently indicates that a decent proportion of paramedics can find answering this question of what to do next quite difficult. Some express uncertainty regarding the accuracy of their assessments for non-conveyance to ED, express concerns for patient safety and their own personal liability if an incorrect decision is made and the patient passes away or experiences an adverse event. They have told us that in some instances the answer is quite obvious to whether someone does need emergency department care or not, for instance if the seizures just aren't stopping or the person has sustained a significant injury. However, they say that this is in the minority of cases. For most people they say they see, the answer is less obvious, as they're not presenting with a blatant emergency care need. For instance, most people presenting to the service with a seizure actually already have an established diagnosis and are on treatment for it. The JR Calc National Ambulance Care Guidelines note that most people presenting with a seizure in such a context will not require the emergency department. However, they too do acknowledge that various factors can make this decision much more complex in practice. It is these factors that likely explain why other research by us and other groups shows that seizures are one of the presentations currently being over-conveyed to the hospital emergency department. Approximately 1 in 5 attendances at English emergency departments for seizures meet the generic and relatively conservative definition of an avoidable attendance developed by Sue Mason and her colleagues and which has been later adopted by NHS Digital. We shall return to this definition later on. What makes the decision difficult? Well, as you well know, there are a number of macro, meso and micro factors. Those which will be consistently highlighted to us as being important include the following. That in 9 out of 10 cases, the person would have typically stopped seizing by the time the ambulance crew has arrived, and so paramedics will often have to rely on patchy information about what has happened from bystanders. The patient might also be alone and unable to communicate clearly about their needs and what they want to happen. be it because they are in a post-ictal state or perhaps have a learning disability. Paramedics also don't usually have access to the person's medical history to allow them to interpret the normality or not of what has happened to them. Paramedics have also been critical of their pre-registration training with regard to seizures, and say they can struggle to get specialist advice when on scene about what has happened. Finally, on top of this, paramedics are clearly working under real time pressures. The longer they spend to see if the patient is recovering sufficiently to be left alone, the longer it is before the crew can get back on the road to be able to help others. So what could make the situation better? Well, paramedics we've interviewed have consistently said what they want is more on-scene support. They're critical of non-conveyance guidelines and protocols, saying they are difficult to apply to the nuances of individual cases. They say that what is instead wanted is some sort of tool that could help them differentiate the needs of the individuals they are seeing. Given this, RADOSS aims to develop and validate a risk prediction tool that could provide paramedics with estimates of the likely risks to the individuals they are caring for if they're left at scene, and an estimate of the likely benefit those individuals would experience if taken to a hospital emergency department. Paramedics could then use these estimates along with other pieces of evidence to help them decide which option is likely best for the individual they are seeing. As you will know, risk prediction tools use two or more pieces of patient information, such as clinical signs and characteristics, to generate a personalised estimate of the likelihood an individual will experience a certain endpoint within a specified time frame. Risk prediction tools do not replace clinical judgment, but rather support it. They can convey risks and benefits succinctly and promote shared decision-making. Arguably one of the most well-known is the QRISK tool used by GPs. Having typed in information about the patient, the tool provides the GP with a personalised estimate of that individual's risk of cardiovascular disease within the next 10 years, and so can be used to guide treatment and lifestyle changes. Ambulance clinicians, just like other health professionals, already use risk prediction tools. JR CULT guidelines recommend 11 of them. Examples include NEWS and the Wells criteria for embolism. However, no properly validated tool currently exists to help clinicians estimate likely benefit or risk of non-conveyance for a seizure. So, back to seizures. What is our current understanding of what paramedics want a risk prediction tool for seizures to tell them? Well, we are here guided by work by colleagues who completed the NIHR-funded Phoebe project. Amongst other things, it included expert consensus workshops that considered what information crews considered to be key when considering conveyance. We've translated this for seizures. Firstly, we wanted it to tell them what are the chances this individual will seek urgent or emergency care again or sadly die within 3 days if we do not take them to the emergency department, versus what are the chances this individual will seek urgent or emergency care again or sadly die within 3 days if we do take them to the hospital emergency department. 3 days was seen as important, as when looking at all types of presentations, it is within this time window that the bulk, i.e. 75%, of recontacts with the urgent and urgency care system occur. The second thing they wanted to know is, if we took this individual to the hospital emergency department, what are the chances they will get a test or investigation that required them to go there? Or in other words, what are the chances of their visit not being classed as an avoidable attendance? RADOSS is going to see if it's possible to develop a prediction tool which, using information available to crews at the time, can provide precise estimates of a person's risks of these outcomes. To do this, RADOSS will be working with the CureD+ database. For those who do not know about this, CureD+, developed by Sue Mason and colleagues, is essentially a cutting-edge, anonymized, linked database covering the period 2011 to 2022. CureD will provide the basis for the risk tool. For RADOSS, what it will do is essentially allow us to identify all people cared for by the Yorkshire Ambulance Service for a seizure over a period of 12 months, and to know what information crews had at the time when they were caring for these people whilst on scene. For each seizure incident, we will have access to any CAD and EPR data that the crews had. We'll also be able to know what happened to them. We'll know if they were conveyed or not. If they were conveyed, we'd know via the ECDS system what happened to them at the emergency department and whether any admissions occurred. We'd also have access to any death data. Importantly, we should also be able to track what happened to these people in the days afterwards. Thus, we should be able to know whether the person made any recontact with the ambulance service or any other part of the urgent and emergency care system within the subsequent days. Based on previous evidence, we are currently proposing that we track and see what happens to patients for 3 days after their contact with the ambulance service and use this information for the risk tool. However, for a secondary analysis, we suggest using a time window of 30 days. Later on, we shall ask for your thoughts on the suitability of these time windows to inform decision making. So why have we asked you here today? Well, in short, we need your frontline expertise to help us ensure we're developing the model in an optimal way. You know better than anyone the data that CureD Plus is pulling from. You know how it is collected, the nuances. You know what data elements you do and do not trust. For paramedics in the room, you also know what it is like to make conveyance decisions, and so you can offer us guidance on how we can make the tool as helpful as possible for crews in the future. There are 4 broad things we want to ask you about. Firstly, candidate predictors. To develop a predictive model, we need to decide what information available to crews we should ask the statistician to seek to base the model on. In other words, what variables to test. For statistical reasons, we can only examine a limited number. We would like your views on which things you consider should be most prioritised for testing. Given your expertise and experience, you may have insights into what might be predicted of the outcomes of interest. In making your suggestion, you might also draw on your knowledge of which information sources are easiest to use in practice, which are available when the decision actually needs to be made, and which sources and measurements you feel are most reliable and trustworthy. We will merge your suggestions and reasons with those of seizure specialists and also service users. We shall ask for your thoughts on what might predict risk of death and recontact after conveyance and non-conveyance for seizure, and then what might predict chances of an avoidable attendance occurring if conveyed. The second thing we want to ask you is for your thoughts on the time frame of the outcome measures as currently proposed, and whether this is ideal to inform crews' decision making. Thirdly, we shall share with you the definition of an avoidable attendance we propose to use in the study. We would like to hear your views on potential threats to its validity due to possible ways in which some EDs are practicing. Beth's going to share the definition with you in due course. Finally, and if time permits, there will be a brief period for you to offer any thoughts you have on future rollout and preferences for the format and presentation of any such tool in the future. We anticipate that your specialism and position in the patient care pathway may mean you feel more comfortable in responding to some of these questions than others, and that is totally fine. Thank you very much for your attention. I shall now hand back to Beth so we might begin to hear your views.